Hello everyone, my name is Raíza, and welcome to one more episode of my podcast, Health Around the World. Today I will be talking to Ashley. Ashley and we met when we were both working as volunteers in a clinic for refugees in Samos. Samos is an island in Greece. And she's a doctor from Scotland, but she spent the last 10 months working in a rural hospital in South Africa. So she's going to be talking to us about her experience. Hello, Ashley. Welcome to the podcast. Can you start by presenting yourself?
So my name is Ashley. I am from Glasgow in Scotland. I studied medicine at the University of Edinburgh and I graduated in 2016. So I really enjoyed medical school. It was, I think people think of medical school as you're going to come out and know everything when actually you just sort of scratch the surface. And the more that I work, the more I realise that, you do not come out a specialist, you come out with really basic level knowledge. And really the focus is on medical school, just kind of knowing when you need to ask for help and knowing how to keep people alive until help comes. After we finish medical school, we do a 2-year program called the Foundation Program. And this is when we're working as junior doctors and we rotate every 4 months around different specialties. And after our first year, we become fully licensed with our medical council. And after the second year, people either go into specialty training or, like myself, it's a kind of natural place to take some time out and do other things.
So after your foundation year, let me just explain. The foundation year is a 2-year training program right after medical school. And so after your foundation year, you plan to work for a little bit and go to South Africa. And how did you end up going to Samos? What happened?
So I finished my FY2 and I'd moved back to Glasgow for the program, and I had planned to go to do some locum work, which is where you're like a substitute teacher but for doctors. And my plan was to go to South Africa in the January of the following year, so locum for a few months and then go out to South Africa. But unfortunately, everything, the paperwork on their end is always a nightmare. But basically, there was a big strike that happened, and so I didn't get out then. So then that was when I kind of changed plans and went to Greece. So I worked on Samos, which is obviously where I met you. So I was there for a couple of months, and during my during my foundation years and the couple of months before coming out, I did a diploma on the side in sexual and reproductive health, and I did training in contraception, so how to counsel women and how to put in long-acting forms of contraception like the Mirena coil, copper coil, and the implant. So my area of interest is women's health, and particularly women's health in low resource settings and their access to contraception. So when I went out to Samos, obviously there was a big focus on my women's health goals and interest there. So I saw kind of a lot of the women patients coming in, a lot of the young women with bleeding problems or wanting contraception, that kind of thing. So I worked, came back home to Glasgow after my time in Samos, which we can talk about in more detail, obviously. And then was basically working in an obs and gynae job in Glasgow for a few months, just kind of waiting until all my paperwork finally came through. And then at the end of November last year, I flew out to South Africa, and I spent the last kind of 10 months working in a very rural part of South Africa, very northern KwaZulu-Natal. where I've been working as a rural doctor in a government hospital there. So that was very interesting.
Wow, that's super interesting. That sounds like quite a experience. So first working in a clinic for refugees and then going to rural South Africa. We're gonna talk more about this for sure. But now I want to know why are you so interested in women's health, especially in these low resource settings?
I always knew that I wanted to be a doctor, but I didn't know. I initially thought that I wanted to do cardiology because I'm from the west of Scotland, and cardiology has heart disease is rife here in the west of Scotland. But then I did a gap year before university, and I already had my place at university. And when I did my gap year, I picked up this book called Half the Sky, literally at the airport on the way to Guatemala. And I read this book. It's a book by two journalists from the New York Times, and it's basically a collection of their essays on the oppression of women around the globe. And it was the first time that I had really thought about feminism and thought about inequality, which, just because I'm so lucky to come from a privileged background. So it really was so eye-opening. And basically from the first chapter of that book, I was like, okay, I'm going to be a gynecologist now.
Wow.
And then when I know it was a very powerful book. It's obviously a little bit outdated now, and there's been so much progress since it was published, I think back in 2009. But it was the first time I've heard of obstetric fistulas or and really things that now I think there's so much more awareness of. But when I was reading this, even just this was like 12 years ago, I had never heard of these things. So yeah, after that I read that book and I was like, okay, I want to be a gynecologist now. And then so I started medical school thinking I wanted to be a gynecologist. And then throughout my studies and throughout my time working in the UK with refugees in Greece and in South Africa, it just reaffirms my goal and ambition to work with women's health, because it's really, the sexual and reproductive health aspect of things that women go through is just, it's so powerful, even from like a societal community level, how much it impacts the rest of their lives and also the lives of people in their community. I mean, it's like, yeah, it's such an interesting field of medicine. So that's why I want to.
Yeah, I understand. Women's health really is very special area of medicine. I really agree. And tell me, why South Africa? Why was this your first destination, even though it didn't work? But why were you and are you so interested in South Africa?
So South Africa had been on my radar for a long time because I'd known people who had gone to work there with this one organisation called Africa Health Placements. Unfortunately, they don't exist anymore. Last year, they went into kind of administration, basically because the government were making it so hard for foreign workers to come and work in South Africa. So, but they were still kind of operating when I went out, obviously. And basically, the whole point of it was, in the rural areas of South Africa, they cannot get doctors to work there. Everyone wants to work in the cities. And then you have this weird paradox where people like me, who want a global health experience and to learn about diseases and pathology that you do not see in the UK or in Europe, I wanted to learn about working in a low resource setting. So these medical posts that are unfilled because they can't get people to fill them, and then there's a huge host of people from Europe who want that experience. So this organisation kind of married up that need with the other. So I have a friend who did it quite a few years before me, so it was always on my radar. And they give you a wage as well, so it's not volunteering, so you can really sustain yourself. And it's just a really interesting part of the world. I did my medical elective in my final year of medical school in Swaziland. Now Eswatini, and I just loved that part of the world. It was the people are so friendly, and it's gorgeous, and there's lots to do. So I knew that I wanted to work in a rural setting.
You were working with a local team of doctors or all foreigners?
So in South Africa, they have once you finish medical school and your internship, you have to do a year of what they call community service, where people are placed in, hospitals that need, the government, basically the government hospitals. So there was a mix of myself and a girl called Hannah, who's a GP from England. We both went out together. And then there were 3 community service doctors there. And then there's a mix. So there was another guy who was there from Switzerland. And then there were South African doctors who are there more long term, like that's their home. They've been there for kind of 10 years. And that was the whole team. Yeah, so there was not many of running the hospital. And basically it wouldn't be, there's not, normally in hospitals you have a real obvious hierarchy where there's departments, there's a hierarchy within those departments. This was very much everyone acts as an independent practitioner as part of a team, but we would refer to the other hospitals via the phone for specialist advice, but really just try and manage as much as we could with the resources that we had, because everywhere is under-resourced and under a lot of strain. And then obviously when COVID sort of kicked off in South Africa, we went into quite a strict lockdown at the end of March, although it took a little while for it to reach where we were because it was so rural. But it was interesting. We had to really reshape the whole hospital and put in these protocols and train nursing staff, and and train ourselves. So it was really quite tough for a while, but a very interesting experience as well.
So since you were in this very rural setting, I imagine that you also had some trouble having access to medications and equipments. How was your access to resources?
Yeah, so it was okay. We very often had shortages of things. And often it was just simple things. From my point of view, obviously coming from a women's health perspective, I was the doctor in charge of the female ward, and the female ward was 50-bed ward, but we would have everything on it, so it wouldn't be split up into surgical, ortho, medical. It would just be all women go into this ward unless they have TB, in which case they would go into the TB ward. So it's very different from the medicine that I was used to, where during my foundation years I worked 4 months on respiratory, 4 months on gastro, 4 months on surgery. Whereas this was, I would do a ward round, and it would be I have to kind of switch my brain into all the different specialties, which was obviously quite challenging. So when I would do my ward round, there would very often be, sorry, there's no, this medicine's out of stock, that medicine's out of stock, or I would prescribe it and the next day it hadn't been given, and because it's out of stock. There's a lot of that. The pharmacy was well run, like it was pretty organized. It's just a lack of funding. And so they say, it's all very well, like, but we don't have enough money to get in, for example, the implant that that I was encouraging so many women to go on. We ran out of stock of that like 2 months before I left. And each week I'd say, when are they coming in? When are they coming in? Very high rates of teenage pregnancies. And, young women having 5 kids before the age of 25 was not uncommon. So from the hospital, there was a few things that were out of stock, which was frustrating. But the more important thing is the local clinics that they work at. So our hospital was very rural, but quite often, people were traveling, 3 hours in a little taxi or a lift or walking, that kind of thing, to get to the hospital. And actually they're served by the local clinics. And we would try to get out to the local clinics once a month. The doctors would try and get out once a month to kind of deal with the more kind of chronic stuff. And it's when they don't have the medicines there that's the biggest issue. So women go and get the injection and it's out of stock, or it's expired, or there's no pills left. People taking their insulin. That's the kind of the tough parts. And then also the other thing is sometimes it wouldn't be other factors that were affecting the way that places could be stocked. So, for example, there was a community protest over corruption in the government. And the community protesters, rightly so, they wanted to do something, but they blocked cutting us off from the main city or the main highway that would go to the city, and so that completely disrupted the transport of medicine to us, and then the knock-on effect is that the local clinics don't get their medicine. There's a big backlog, and so what would normally be the right shipment is out of date, and then we don't have enough. Well, the medicines wouldn't be out of date, but what I mean to say is that the stock levels are now low. We have to replace what's depleted. So working in a place that's got a little bit of kind of hostility and quite a disruptive place, it can add these little or quite big challenges.
And I've also read that they have a high maternal mortality. I don't know what's the reason and if it's still.
Yeah, so I mean, when you look at the rates, I think we land pretty much. We're definitely in the first half, and other countries in Africa have much higher maternal mortality rates than South Africa does. But I think it's a reflection on the government hospital versus the private hospital, that it's not as bad as it could be. I think if it was if there was no private hospitals in South Africa, it would be much higher than it is. So again, it's an interesting point, because South Africa has so many cultures in it. It's a challenge much more so in, for example, the Zulu community than it would be in the community of Cape Town. So there are issues with polygamy. There are very, very high rates of HIV and TB. And so quite a lot of pregnancies have, complications with STIs, with syphilis. There's a huge number of reasons why the maternal health care is quite a challenge. HIV has probably got a big part to play in that. And then also, as I'm saying, the resources, it's a big country, and the travel between these rural communities and the tertiary centres is really key. So one thing that we did at our hospital, we're obviously not a tertiary centre, we're just a local district hospital, but if people have very severe complications, we'll try and manage them as best we can where we are, but sometimes they do need to go to a more robust tertiary centre. Like, for example, women have a really, really bad hemorrhage after they give birth, or during or while they're giving birth. quite often we had no emergency blood, or we had, one unit that had to last us the weekend. There was times where we really had to, kind of every day almost, was there's someone who could do with emergency blood, can we give it? And it would have to be a way up of when's the next thought coming in. And so what we would do in our hospital is, if there was any complications that we would foresee, if the placenta was low lying, or baby wasn't growing well, or any problems, then we would try and get them to the tertiary hospital sooner rather than later. And then women who lived really far away, so if they went into labour and there was any problems before, and they knew it would be hours before they could get into the hospital, which was the case for so many women, we had this thing called quasi-hambate, which kind of means like almost like home, and it's where they would come 2 weeks before their due date and stay there. And it was amazing because you see these women all still pregnant, walking around the hospital grounds, trying to kill the boredom, and it was a shame because they obviously weren't with their families, they weren't with their partners, but it was nice that they were safe. It was much safer for them to be there with them amongst all the other women than to be at home. And I think that is a really key way to sort of reduce poor outcomes, is to have the women who are going to give birth relatively soon in a safe space.
Yeah, that sounds like a big challenge. And you've also mentioned this very young women pregnant, or very young women with 2 or 3 babies. How would you say was the level of awareness about sexual reproductive health?
Yeah, so the health education in South Africa, and especially because I was working with Zulu women, I didn't treat any white women ever in my time in South Africa. The health education is poor. That obviously has to be addressed first and foremost. But I do find that it's actually not too dissimilar to here in the UK. Generally speaking, people have a really poor understanding of contraception, how it works, and the reason is because it's complicated. It's really important. It's a really, really important part of sexual and reproductive health and of women's health, but it's not straightforward. It affects everyone differently. There's a whole host of myths, and there's a whole host of reasons why contraception is hard to understand for anyone, let alone people who have never had any formal health education, and who don't really engage with education or with GP, with doctors. So I wouldn't say that is solely a low income country issue. I think over the world, contraception is poorly understood. The way that I deal with it, thinking of South Africa as an example, is I keep it really basic. And I think the problem with contraception is there's so many options that people can feel overwhelmed. And what I like to say is, you don't need to make a decision now. Take the time to think. Here's a little picture of the different types. I'm sure you maybe remember my leaflet that I had.
I do.
And
the small uterus you had and everything.
Yeah, and I think it's because it's a lot of information to take in one go, and ultimately it's so important that women understand that what works for their mother or their friend might not work for them, or equally, if they've heard a horror story of someone who had the implant and they bled constantly, that is not to say that will happen to them. But yeah, I think in South Africa in particular, there's really poor education, and also they are, in where I was, a very sexually active population, and there was a huge social issues, which obviously isn't my job to sort out, but it really affects the general health of the women there. So things like grooming, young, teen pregnancies, and often below the legal age of consent, being pregnant by a 20-year-old or 25-year-old, and yeah, it's tough, and the police, it's so systemic, and it's so sort of accepted culturally that that not much gets done about it. And my colleague who runs the maternity services, he is amazing, but it's like banging his head against a brick wall with trying to sort these real issues, cultural issues out. It's really, really tough, and it's also incredibly sensitive.
Yeah, this seems tough, but I understand that when we go to a different country and experience a different culture, there are some limitations that we will have to accept. And my next question related to this, what would you say to someone that wants to work in this type of setting, low resource settings?
So I get asked quite a lot about how I organise things and what I've done and what's the best route. I guess if the want is there, then the issue is the practicalities of it. And I think the best thing to do is just to get in touch with organisations. A lot of places, like for example, with Mediquality, and with I volunteered as a medical student with an organisation on Lesbos. And it really was just kind of, most places have a social media page, have a Facebook page or a website, and there's no harm in just sending an inquiry about, what your experience is, whether you'd be useful or not. And I think the key thing is if you're not going to be useful, then don't push. Like, just there's always a use for someone somewhere. Especially if you've got kind of drive and you're passionate about it. But if something's not the right fit for you, don't force it. Just like move on to the next thing. And yeah, so I would just get in touch with I always say just kind of get in touch with organisations. Unfortunately, I would have in the past advised people to go through Africa Health placements if they wanted to do that, but they don't work anymore. So working in Africa is maybe a little bit more challenging now, but again, there's lots of there are lots of organisations that you can organise electives and things with. And I think if you have a contact at a hospital, then that really helps. But sometimes that is literally just emailing or calling the hospital straight up. People are very accepting of help if someone is qualified and willing to help. I would say it's important that, and it's something that I'm working on as well, is not to think you know everything. Not to think that because you've got a medical degree that you are qualified to do, because healthcare here is so different from healthcare in South Africa and in Samos. Here I'm supported by consultants. I've got X-rays, CT scans. Whenever it's completely different from working elsewhere. And I think actually the important thing is only to work outside of your limits if there is literally no other option. Otherwise, don't think you're invincible just because you're working in a healthcare setting. I would never want to think that the rules don't apply somewhere else just because you're volunteering, or because it's a person who's displaced and isn't a citizen there. Everyone has to have the same level of respect as you would treat patients wherever you're practicing. So that's like really key to remember.
Do you have any powerful stories that really marked you that you would like to share with us?
In South Africa, there was one night where there was a road traffic accident. It was crazy. There was I laugh now, I was not laughing at the time. There was a road traffic accident, and these three guys were super drunk, but they'd fallen off the back of a pickup truck. Anyway, one had like multiple broken ribs. One had internal bleeding, and the other had broken his neck and couldn't move or feel anything from the shoulders down. And you know, it was the middle of the night, and I was the only one in. I called one of the other doctors to come in and help, but basically they were seeing the queue of other people who were in the car accident. It bashed into one of these minivans. So it was just like, you know, I was putting in a chest drain here. I was trying to organise referral to the hospital there, getting X-rays, doing log rolls. It was just like, it was just crazy. It was just absolutely crazy. And then I was trying to get the one guy, I had to put him on medicine to keep his blood pressure up. He was needing all the oxygen I could give him, and still wasn't doing well. And yeah, oh man, we tried to arrange an ambulance, and there was no ambulances. So they said they'd send a helicopter at 7 a.m. Helicopter never came. It was just like crazy. And unfortunately, that guy didn't make it. He died after 12 hours of me trying to keep him alive. He did make it on the helicopter, but it didn't come until the afternoon, and then he died shortly after getting to the tertiary hospital. But those kind of things, it's sad looking back on it, but it really is like the other two guys survived. That's the really cool part of the job. You see stuff that's really, in Glasgow, I would never have even been in the room, and you just have to crack on with stuff. But the best part for me about working, it's kind of boring, but when I just start a young woman who's had a miscarriage, or someone who's in her last year of school, and I tell her about contraception, and she is like, oh yeah, no, I'd really like to do that. You know, that to me is the best part of the job, is that like you, and I mean, I think the pharmacy was really raging at me for like depleting all their stocks so much. But I think that is the key thing, because with sexual health, you're not just changing like that person's health, you're literally changing, you know, their opportunity and their what their future might be. And yeah, I think that's the best part.
Yeah, I can see you're very passionate, and I've seen it before. You're very passionate about what you do.
Yeah, I love it. Yeah, awesome. Well, thanks for asking me questions. It was quite nice reflecting on everything.
So, thank you so much.
You're welcome. Have a nice day.
You too.